Actually, last year, right before the publication, we presented an early form of this, and Dr. Jenser is in the audience and heard this, and we collaborated. So I would like to tell everybody about this. Disclosures, I work with some industry. None of them have anything to do with this classification. So in terms of our outline, we need to be able to identify, communicate, and predict. That's really what we're looking for when we're taking care of cardiogenic shock. And so to identify cardiogenic shock, the good thing about going on day 2 is that everybody's heard these before. You already 5 minutes ago heard the definition of cardiogenic shock, which hasn't changed. And everybody, if we had a nickel for every time we've seen this figure, I just put the red around the point on the left to make the point that we don't know how to treat what's on the left. We just treat what's on the right because that's what we know how to do. And as Dr. Rame said, to understand the endotheliopathy, to understand these others will really bring us forward. But then how do we communicate? So I think, this was actually born out of an observation from a variety of us that are in the clinics taking care of patients in the ICU and pointed out that we just have no way to communicate. How many times do they send you a patient and say, oh, it's really bad shock, everybody's ready, the surgeon's there, patient rolls in, they're sitting up reading the newspaper, they're fine. And I'm like, really? That's shock? And other times they say, oh, the guy's a little bit sick, and then they come to you horribly ill. So we have apples and oranges. We have to get the language right. For example, if they tell you, gee, Dave, I'm going out of town for the weekend, can you watch my cat? Sure, there's no problem, why not? Except that they may not have told you all the details. In fact, it may not be that simple. That's a cat too, but may not be one that you wish to watch. So many of the authors of this document are here in the audience today, and it's really a collaborative effort of everyone to derive this. And the point was that we decided if we're going to redefine something as complicated as shock, we needed a multidisciplinary lexicon. So we have involvement of all the disciplines, including critical care nursing, and the end document was endorsed by a variety of societies. The goals of the new shock definition, lots of things written, but the essential thing is you could boil this down to the KISS principle. Keep it simple, stupid, because I'm not a really bright NIH-funded researcher. I want a quick way that I can communicate with colleagues, from my EMS colleagues to the bedside nurse to the advanced practice folks to everyone else. That's really what the key is. You need to have something that doesn't require an app, doesn't require a calculator, not so difficult to actually immediately get it. So I think we've in some ways succeeded, and you've all seen the pyramid. Stage A, at risk. The idea being that these are patients who are potentially at risk, redefining people that normally were never thought of to have cardiogenic shock, but in fact are obvious. If you come in with a non-STEMI, maybe an early STEMI, you definitely are at risk, including our heart failure patients who run around with EFs about the same as their shoe size. They're clearly at risk for cardiogenic shock. Then beginning shock, defining those who are not hypotensive or tachycardic, but are still well perfused. Oftentimes you see this. You see patients who you do a right heart cath on, their cardiac index is terrible, but they're laying on the table patiently waiting for you. They're feeling fine. They're maintaining their end organ functions. Versus classic cardiogenic shock, which really, and on these blue tables, in the interest of 7 minutes, there's no chance to go over all of this in detail. But realize that the way we drafted the document is to point out that there are hemodynamic, physical exam, and biochemical indices. And in many ways, it's sort of like choose one from column A, one from column B, and one from column C. The point being, you can study the document and then basically walk away being able to classify patients without having to be a slave to, oh, the lactate's only 1.95, they're not in shock. Well, if they're sick, they're in whatever stage you call them. And then the important 2 aspects were deterioration. Patients that are deteriorating, defined by whatever you chose first. So consider everybody's house is different. In your hospital, you may say, well, the first treatment of choice is ECMO. In mine, it may be a balloon pump. In somebody else's, it may be a tandem. The point is, deterioration is you didn't do well with whatever was chosen first. And then extremis is probably the easiest to recognize. As you walk onto the unit and you see people running in and out of the ICU room and everybody, in a flustered mess. Of course, that's the patient with extremis with cardiovascular collapse. How in the world is an E the same as a D or C? To us, it was very straightforward that we have to separate these. And then the risk modifier for cardiac arrest, a very important observation that you're really on a different trajectory if you have an arrest. That means even a single bout of shock because of ischemic VFib versus perhaps patients going on with long-term, taking a long time to resuscitate. And I'm going to skip the cases, actually, just to briefly say that, beginning cardiac arrest beginning cardiogenic shock is a patient who comes in with heart failure, perhaps with chest pain, so forth, but still well perfused. Case 2 would be a patient who comes in looking very, very poorly, hypotensive, tachycardic. Most people would recognize that this patient actually, by physical exam, don't need a swan to determine that, in fact, that patient's in classic cardiogenic shock. It's not that we want to dumb it down and remove all the things like swans and all the things that we love, but the point being, you don't need all the technology all the time to decide that, okay, this person's hypotensive, hyperperfused, looks like junk, and is in cardiogenic shock. And then it's not so hard to tell if the person is, arrested at the Costco, telling his or her, his spouse that he's at the big one, and patients are resuscitated. They come in, and oftentimes ambulance folks will come in and tell you, well, patient's okay. Yeah, okay, on 20 of dopamine, wide open fluids, looking awful. That patient is deteriorating. Our dream is that eventually, across the care spectrum, people will be able to call you and say, I got a SCAI-D here, it's coming in, and maybe go ahead and prospectively transition the patient over to a shock center. If that patient has a STEMI, they send the ECG, and they go to a center that can take care of it. Why in the world would we send shock to a place that's not able to do it? And what about predicting? And you've seen Dr. Jenser's paper that we wrote, and just pointing out that this was based on 10,000 patients in the Mayo Clinic ICU. And you've seen this figure as well, which is well shown. It's really gratifying, an idea that 14 of us came up with to try and decide if this works. It made a lot of sense to us, but actually that you could validate and show that it really does predict survival. Importantly, however, I've never seen anybody show this one, which is table 1 of his beautiful paper in JACC, which is the definitions. You could actually take EPIC, and for once in this millennium, you could actually find a use for your medical record system, which is the EMR could actually tell you what the SCAI stage is. If you look at this, you can actually see that the different classifications are made based on blood pressure, vasopressors, and it would not actually be hard to imagine EPIC being able to give you a SCAI stage. Importantly, it's the same whether it's heart failure or ischemic shock, so I do think that, in fact, the value of this is it doesn't matter. Shock is shock is shock. And then Dr. Westerman is in the audience. It's nice. He actually did a beautiful paper published in CCI just recently about the classification of shock and showing the same thing, that, in fact, you're able to actually predict mortality, and that's really the value of this. So in conclusion, cardiogenic shock, we have to do something different than what we're doing. We've not improved survival at all. And hopefully with knowing this classification, is it perfect? Absolutely not. But it's a place to start. It's better than where we've been for the last 20 years arguing and debating. And now that we know at least one way, and maybe over time we may change it, that is half the battle. Hopefully we can improve the dismal survival that brings all of us together to try and help these critically ill patients. I thank you.
Thank you very much, David. Because of scheduling conflicts, I think we're going to actually have a little bit of extra time, and we'll try to take advantage of you while you're here. My first question is, what we found in this mechanical support trials, balloon pump, MCS, whatever, age is a huge prognostic determinant. And you're using a cardiac arrest modifier, but what about a modifier for someone over age 80 where the mortality really skyrockets? So I just wonder if you could comment a little bit about that interaction.
That's a great question, Bill. So, age certainly does predict. It goes into all of our things. It's why I think shock teams work, because you go to the bedside, you have multiple people looking, and certainly there's sometimes patients that are biologically 60 years old but truly look to be 80 or 90 years old. Jake?
So Dave, great presentation. I enjoyed it as much as I did last year. So it's actually good that you bring this up. So at the 3CT conference last weekend, Susanna Price was saying that when she is triaging patients in her hospital system, she actually uses SCAI stages and age. And she put up a table which is basically, at which SCAI stage, at which age, she will accept a patient for transfer for advanced circulatory support. So your question is extremely insightful and I think very practical when we try to apply these in our patients.
I worked as a burn tech when I was an undergrad, and they had a classification based on the percent of third-degree burns and the age. And so if you had an infant with 30% third-degree burns, they were like a 95% mortality. And if someone was over age 80 with 5% third-degree burns, they were still 90% mortality. Conversely, if you had a person that's 45 and had 40% third-degree burns, they still had a very low mortality. So I think, and it is going to be very important, especially when you start talking about a lot of these incredibly intense, expensive therapies. Are you going to do bipella in a 90-year-old? I don't know. I mean, I think those are some of the important questions we have to start thinking about.
All right, I think this is definitely true, very, very important, because we're all rated based on the survival of our patients. Everybody ultimately has to look and say, what are the costs? Even if the bipella were free, there's a patient cost to the devices. So I have no doubt that in 5-10 years, the device costs will all come down. With competition will come lower costs. I do also agree with Dr. Rame said this morning, that we really need to understand better. In sepsis, we're a little bit further along, although despite all that effort, we haven't really cut the mortality much more than giving IV fluids. I do think that if we at least unite around this common sort of language, it will help us from the day-to-day about figuring out what to do. But indeed, point well taken, if you have a 70-year-old SCAI D or E, perhaps it's time to call palliative care colleagues and not torture the person for the last 12 hours. It may be 12 hours regardless of whether you put devices in or you don't.
Ali?
David, great presentation, and really congratulations again for that work. It's a great step in the right direction. I'm going to address one of the problems we're facing, and back to the comment from Dr. Neal regarding how to get the patient early on, because those patients usually in referring hospital is managed by hospitalists, will not be able to get all that classification and give me idea about kind of patient. That means what probably we need a simplified classification for that, not to ask them for many things, because those guys in the middle of the night, there's no cardiologist there, there's a hospitalist taking care of ICU patient in cardiogenic shock. How to make a simple classification for him that he can in the middle of the night tell you and what's the patient having, to send the patient to you before getting 3 or 4 inotropes. That's the thing, I think the next step we have to think about. If you work in a hub and spoke model and we're going to teach, we have to go to their level and not to have also to talk about us here working in academic institution and know what we deal with this patient. 90% from PCI patient are done in small hospitals, does not have that kind of expertise we having here to manage those patients.
So it's a very interesting question, Ali, but I would tell you that I presented this classification, for example, to a convention of 2,000 first responders, EMS, and EMT. And actually, one of the comments is that this is straightforward because actually one can detect what the patient's stage is. I think as well, we sell our colleagues short in bedside, critical care, non-critical care settings. Most people can actually identify these stages. So I think that the fact that you don't need a swan, you don't necessarily need lactate, you take the information you have. For example, an EMS is the construct. That probably means you need to get off the stage, but that's all right. I'm a New Yorker, I'm tough. There's a concept of sick, not sick, where in EMS literature, you can say, well, everybody can recognize what's sick and not sick, and one could take the same adaptation that a SCAI C and higher, clearly patient looks sick, and B and less, patients don't look sick.
Let me ask you a quick question related to what Ali's talking about and a more generic thing. I think, all these sort of granularity classification schemes are great. The issue is use and adoption and speed. I think it really would behoove us, just the whole general medical community, for whatever you're looking at, whether it's TIMI risk score from the old days or Parsonet scores from the old days or your new classification. How many people are going to use it? How quickly can it be calculated? How do we really make it so that people adopt these type of strategies, even if they're not 100% baked? And I think that's going to be a very important thing, because we really need to see field use and make things simple, to Ali's point, to be able to be used. Because otherwise we've got a melange. It's like a cookbook. We have 50 different classifications, and is it really going to help us? I think they do, but they have to be made utilitarian and widely used to then see how it's going to impact things.
So
David, this is probably an appropriate forum to reveal that Ali and I have developed, taken your work and taken it to the next step with the modified SCAI score, which goes like this: 1, 2, 3, 4, 5, A, B, C, D, E. How many nurses are in the room? 1 is an A, 5 is an E. Okay?
I would agree.
You can put that on a business card.
I think the SCAI score is exactly as they said, like the recognition of obscenity or pornography. Once you understand the system, you can intuitively say, wow, this makes sense. You may have slight differences, but I think everybody can recognize the patient is dreadfully ill. Everybody can recognize the patient's okay. And I think actually pre-hospital providers, certainly any ICU nurse, could recognize very well between B, C, D, and E.
How long does it take to calculate your score?
As quickly as you think. It's a gestalt, because there is no score, there is no app, and there's no requirement that you have to have one of each of all the different aspects.
I really think we need in medicine to do that type of really simple analysis. You can almost get a high school student to start looking at this in terms of the speed, because that's important. And
Yes.
if it's too complicated, you can't remember it, it's not going to be used.
Just one comment, David. So to the point of how useful this is, C to E is dramatically a step forward because we know we're not dealing with B. But
Correct.
C to E in 1 hour, and then they land in your chopper, let's say you go up and see them, all bets are off what they are then. And that's what I was raising with Jacob and others at the Washington, D.C. conferences. You guys must have had discussions about transitions and dynamic state of this, where this is where I think, I don't know if Marvin's getting at this, but if we had, like for example, a troponin. If the troponin goes up, you don't say that person's in trouble. I mean, you say the person has a heart attack and we got to manage it. Similarly, how do you say this person is in the hole right now and we're going to bring him here now, no matter what the C, and that's what I want to ask you. Have you been able to think about that so it could get a little more refined?
Sure. So that's a great question, Eddie. So that's based into the initial document, the way we came up with it. So consider, D is not hard. You got worse. Whatever you did first didn't work. I don't know how to make it any simpler than that. You failed the exam, they let you retry it again, you still failed it.
But what if you did nothing in the field? What if the paramedics just are trying to figure out what happened to this man who's down?
Well,
And
they know they tried a bag of whatever trail mix they had handy, the patient still looks like junk. Okay. They know they probably shouldn't bring them. Conversely, let me take it a different way. Your outside feeder hospital that's not sending to Penn or now Jefferson, they switch the Penn card and change it to a Jefferson card, all right? They know if my patient deteriorates, the mortality from Genser's paper went up quadruple. So, like Clint Eastwood would say, are you feeling lucky? If you're in a hospital that's a little small hospital and you know your patient's mortality went up by 4 times, you better have your seatbelt on. Or better send it to Eddie, like Mikey. Eddie will take it.
So one more question. One more question, Dr. Carr.
Yes, of course, this is a great step in the right direction, and we needed this classification because we've been talking about this for a long time. But those of us who have practiced the first paper, which was presented in the first talk, the Killip and Kendall classification of cardiogenic shock, it got a real boost on hemodynamics after the Forrester-Chatterjee surrogate for the hemodynamics came. And that's where we started talking in the same language. What I'm thinking is this is great for clinical care, the A, B, C, D, E, which you've done. But even in A and B and C, there has to be granularity. If we have to compare our data in treatment, where we will need to have hemodynamic parameters, because a person who goes from A to E in 5 hours is very different from a person who goes from A to E in 6 days.
I think that's very true. We need more data.
So we have to have the hemodynamic surrogates, not for the general population or the general community, which I think this is a great job, but we will need granularity of the spectrum once we come to shock centers so that we can then compare the data. Because if I say I'm treating a shock patient in E with 2 pressors and an Impella and compare it to someone who's treating shock patients with 4 pressors on an ECMO, these are 2 different people. Both are in E, but this is E1 and E2. So I think we'll need to have some granularity going forward for shock centers to compare therapies.
True. I think, vasopressor score is another very good thing to use, like from the that table in Jenser's paper. Vasopressor score, you really could actually get to the day where the EMR reminds you and says, gee, doctor, puts another alert, actually one that might be useful. Do you realize that the VIS score has gone up by 3 times in whatever period of hours? Big Brother is watching every note we write, and yet it's silent. So I think I agree with you, but there's a lot of ways that we could leverage the computer that knows everything about our patient but does nothing to actually help us and point out the obvious sometimes that you're lost in the weeds, that, the overall situation is getting much worse, rather than just telling you didn't put them on the heart failure pathway or some such rot gut.
Great debates. One more last comment, please.
Yeah, just congrats again. That's a great classification. I really like it. But to water the wine a little bit, to be stimulating the discussion even more, I think there's a couple of steps that you need to take. First, all the validation are retrospective, so it needs to be prospectively validated, right? And I think to really put it in work, and that we all use it not only this year but also in 5 years, we need studies to be based on it, and that needs to start now. And I mean, that's obviously what's tried with B and A and stuff like that, and the same is true for D and E. I think this tool is not only a clinical tool, but it'll really trigger new research, and that's, I think, a big part of that, and that's a great story about it.
Fantastic discussions, but we have to move forward. Thank you so much, David.